I'm Ruth O'Regan. I'm a professor and chair of medicine at the University of Rochester. When we think about cancer genetics and cancer genomics, we use the words somatic and germline. So germline mutations are basically a mutation that an individual has that predisposes them to a cancer. So a very good example of a germline mutation would be the BRCA gene. So BRCA1 and BRCA2 are considered germline genes. The somatic genes are ones that are found within the tumor itself. So they tell you kind of mechanistically what the biology of a given tumor is. And more we're seeing treatments basically targeted towards the genetic makeup of an individual tumor. Now, of course, the two things are not separate. So you can have somatic mutations and germline mutations together. So what's very interesting is what we found with BRCA is that there are patients that either haven't had BRCA testing, or maybe they had BRCA testing many years ago, and you send their breast cancer off for somatic testing, and what you find is a BRCA mutation. And most times when you find that, you go back, and if you do germline testing, you actually find the germline mutation as well. So the germline mutations are detected either by taking a blood sample, or you can actually just do a swab of the cheek or saliva to check for it. The somatic mutations are, as I said, in the tumor themselves. Somatic mutations can also be acquired. So a tumor may not have a mutation to start out with, but it may acquire it over time, particularly as it's exposed to different therapies. So an example of that would be mutations of the estrogen receptor, which are called ESR1 mutations. You hardly ever see them in primary cancers, but they're actually seen in about a third of cases in patients who've had aromatase inhibitors. So all of this is really very important and very exciting, because by determining if patients have germline mutations, not only does it kind of tell us what cancers they're predisposed to, but more and more we have therapies that we can utilize in these patients. So for example, PARP inhibitors. So PARP inhibitors we know work in patients with BRCA1 and BRCA2 mutations. And that's been known for a long time. And actually, these drugs are approved both in breast cancer and in ovarian cancer for patients with BRCA mutations. But what we've actually heard about at ASCO last year was that in patients with PALB1 mutations, which again, you do see in patients, and they are part of the panel that we run, that those patients actually appear to get a lot of benefit from PARP inhibitors. And on top of that, and kind of relevant to this particular topic, is the fact that if you have a patient who has a somatic BRCA mutation, they also appear to benefit from PARP inhibitors, which is kind of what you would expect. But it gives you another way of kind of determining whether a patient's going to benefit from these agents. So more and more we see this. So another example of a somatic mutation where there's a therapeutic approach would be PI3 kinase mutations. So they're common in breast cancers. They're not acquired. Typically, they're present in the primary cancer and also, in the metastatic cancer. And we now have a drug, a PI3 kinase inhibitor called alpelisib, which is approved for patients with hormone receptor positive metastatic breast cancer where the tumors have a PI3 kinase mutation. So I think the indications for germline testing have expanded quite extensively over the last many years. I think we'll probably reach a point where we'll end up testing probably the majority of patients with certain cancers for germline mutations. And again, more and more, particularly in the metastatic setting, we are sending off tumor for genomics to look for somatic mutations. So that really has become the standard of care. Particularly in estrogen receptor positive breast cancers, because of the therapy that we have in that setting.